Hello, and welcome to the first of 4 Lunch and Learn webinars. My name is Shauna Fenwick, and I will be your host for all 4 sessions. This series is in follow-up to the virtual Heads Together think tank held last fall. And we're hosting these Lunch and Learns because June is Brain Injury Awareness Month. We want to foster conversations amongst all of us in these sessions with the aim that you'll leave with insight and ideas on how to raise awareness of brain injury in your own community. Today's topic is Behind the Bruises, Intimate Partner Violence and Brain Injury. You will also hear the acronym IPV for Intimate Partner Violence. While we meet today on a virtual platform, I would like to begin by acknowledging the Indigenous peoples and traditional territories on which all of us live, work, and play. In Victoria, we live and work on the traditional unceded lands of the Lekwungen-speaking people, the Esquimalt and Songhees nations. Please join me in a moment of reflection to acknowledge the Indigenous peoples and ancestral lands where you are joining us from today. It's now my pleasure to introduce to you someone who may not need very much introduction, Janelle Brice-Biagione. Janelle was the inspiration for and the project manager of the Heads Together think tank. She's also the founder of the Constable Gerald Brice, or CGB, Center for Traumatic Life Losses. Janelle, would you please join us and launch today's Lunch and Learn?
Thank you, Shauna. Welcome, everybody. I'm so pleased to have you here to support us and to continue the conversations that we started last fall about the intersections of mental health, addiction, and brain injury. And today, our session, we're leading off with 2 pretty dynamic speakers and a very big topic that's happening across the country, not only in British Columbia, but it's important and we're all passionate about it. So just to give you an idea that the purpose of today's session is that in recent years, and it is very recent, that there have been startling statistics arising around the number of women who have suffered a brain injury as a result of intimate partner violence. In fact, it's estimated that over 250,000 Canadian women live with a brain injury as a result of intimate partner violence. It's sad and challenging for all of us in this field, but we have to admit that for many of these women, they likely have more than one brain injury, and the timeline of when these injuries occurred could span decades. They may have been undiagnosed, and they may not have received any services specific to the challenges that they live with. The purpose of today's conversation is to offer information to assist viewers in recognizing signs of a brain injury that can result from intimate partner violence, to recognize the challenges of living with a brain injury, and the need to use a trauma-informed approach. Both of our guests are extensively involved in raising awareness around this issue and educating frontline workers. We do want to acknowledge that this session could bring up quite a bit of emotion for some folks. And if we were together in a venue, we would have counselors on hand, and we can't do that virtually. So we want to provide our viewers with some information as to where to go should you feel at risk or the need for some support during or after our segment today. Paige is putting into the chat box how to find assistance in your own community. We want to urge anyone who feels that they are in immediate danger to call 911. Thank you, Shauna.
Thanks, Janelle. Before we begin, I'd like to say a special welcome to Megan Kelly from Nova Scotia. That's a fabulous reach, and we're really pleased to have you here. Wow, coast to coast, that's great. We are well supported in this webinar by Paige Corbett and Paulina Kostecki. While they're doing a lot of behind the scenes work, you'll see them mostly in the chat. Paige and Paulina are graduates of Mohawk College's postgraduate certificates in brain disorders management and concurrent disorders. They're doing field placements with CGB this summer. All of our sessions will be recorded and posted on the Heads Together think tank website. Now, that may take a few days. You can watch the recordings at any time, and we encourage you to send the webinar links to others who might not be able to get to our Lunch and Learns. Today's session will go quickly. We're committed to finish by 1 p.m. Pacific time. Our format will be similar in all 4 webinars: an interview, breakout room conversations, and then back to the main room for further discussion. Our aim today is to foster constructive conversations. We ask that you listen with an open mind, stay on topic, and engage in a respectful way in chat, in breakout rooms, and if you speak in the main room. One last announcement, we'll be limiting the chat function to only connect with hosts during the interviews, just to keep the activity of the chat box low so you can focus during the interview. We will reopen the chat to all after the interview. Before we dive into today's session, we'd like to know who is with us today. And I'm going to begin by sharing my screen. There. We are using the Mentimeter platform for our polls. As mentioned in the note with the Zoom link, your answers are completely confidential. As you see on the screen, could you use your phone or a separate browser on your computer and go to menti.com, and you'll see that at the top of the slide on this screen. And once you get there, it'll ask you for a code, and you can type in the code here, 18171412, and Paige will put that in the chat box. After you enter the code, you'll see a screen where you can choose the phrase that best describes you. You may have to scroll down to see all the choices, and you can choose up to 3 responses if you relate to more than one, and then click on submit to send your answers. And we should see who's here show up on the screen. Wonderful, excellent, thank you. We've got a couple of people loaded on this fast. Beauty, good, good. So I've got my screen off to one side. We've got healthcare workers. Wonderful. Healthcare workers coming to learn more, not directly employed in brain injury or intimate partner violence. We've got 6 people. I'll give it just a little bit more time. Work with people who've had a brain injury. Wonderful, great. That's 9 people, 10, excellent, excellent. We're going to be using the menti.com for our poll at the end. So after I unshare my screen, you can actually keep your phone or your browser on that site, and then it'll be ready for you to go next time. So it looks like we've got a pretty good diversity here. We've got people who have had brain injuries and who've experienced intimate partner violence. We have folks who work with folks with brain injuries with intimate partner violence and not. So we've got a wonderful diversity of people. So thank you everyone for completing that poll. It's now time to introduce our guests. Karen Mason is co-founder and director of community practice for supporting survivors of abuse and brain injury through research, also known as SOAR. This community-based research initiative looks at the connections between brain injury and intimate partner violence, or IPV. A longtime women's advocate and passionate changemaker, Karen was formerly the executive director of Kelowna Women's Shelter, which offers free emergency and transitional housing and support services to women and children fleeing intimate partner violence. Our second guest is Tori Datch. Tori works as the community program coordinator with Cridge Brain Services in Victoria, serving survivors of brain injury and adults living with fetal alcohol spectrum disorders, developmental disability, and autism. Tori shares a lead role in Cridge's IPV brain injury program and is currently developing training for health professionals. Tori is also the chair for the CGB Center for Traumatic Life Losses. Tori's passion is the expansion and delivery of brain injury services. Welcome, Karen and Tori. Janelle will be interviewing Karen and Tori, and we have about 20 minutes or so for the interview, so let's get started. Over to you, Janelle.
Great, thank you, Shauna. Well, I do want to welcome Tori and Karen here. I know both of you know how much I appreciate the work that you're doing, but I do want to publicly say how much both of you have been instrumental in the work that we're doing at CGB and our interest in intimate partner violence and brain injury and what will happen for these women and also what will happen to the men who have been involved in this. So I appreciate you being here. I'm excited to have you here. I know that you both have just a wealth of knowledge to share with us, and people will learn a great deal from you. So to kind of start this, I'm going to ask you some questions, but I'm also just going to give you a brief opportunity to share with us the work that you're specifically doing in each of your areas, and then how you came together is going to come through with those questions. So let's start with you, Karen. Perhaps you can share with us just a brief overview of what you're doing in your work with the SOAR project.
Sure. First of all, let me acknowledge that I'm coming to you today from Kelowna and the unceded and ancestral territory of the Syilx and Okanagan peoples. It's a beautiful place to live and work and play, and I'm honored to be here. Particularly honored to have been invited today. Thank you, Janelle, and it's lovely to share the virtual stage with Tori. On the SOAR project, we have 3 key pieces we're working on. We're trying to cover the whole gamut on this topic. We have explore, educate, and empower. And our explore phase is looking at the science behind how often this is happening to women and how it's affecting their neurocognitive function. The educate phase is creating resources, workshops, tools to educate pretty much anyone who works with women who've experienced intimate partner violence, but also to educate women themselves so that they can really be more aware of this issue and that it might be affecting them and advocate for themselves. And then the empower phase is where we are creating and testing and measuring the efficacy of rehabilitation programs and other support systems and bringing those together in the community to support women who've experienced a brain injury from intimate partner violence. And those of you who work in the brain injury community know that it's difficult enough to find brain injury informed services for those who've experienced a brain injury. But when you add that lens of intimate partner violence, it gets that much more complex. So that's a bit of a summary of sort of the 3 pieces. And there's a whole bunch of stuff happening amongst that I'm sure we'll talk more about.
Great. Thank you, Karen. Great. So Tori, as Shauna mentioned, Tori is also the chair of our CGB Center, and she works for the Cridge Center for the Family, where I used to work as well. So Tori and I have been colleagues and friends for a long, long time, and I love her to bits, and she does an amazing job at everything she does, and it always arrives with a smile and super supportive to people. So, it's just been fabulous to have her on board, and she's become, along with Karen, a real thought leader and action person in this field. So Tori, how about you share with us now where the Cridge is at in their work with intimate partner violence and brain injury?
First of all, thank you. Thank you for organizing this and for that very kind introduction. I'm really excited to be here because I actually feel like I can't talk about this topic enough. I get super fired up, and knowing that this is only an hour is going to be tough because it's really easy to go on tangents on these conversations, and it's such a passionate topic. So the Cridge has actually taken a 5 candle approach, we're calling it, 5 pillars, 5 candles. And we're really trying to look at this issue holistically. So there's a prevention, there's advocacy, there's research, there's direct services, and there's training. So Karen and I have crossed paths quite a few times when it comes to that advocacy, that research, and that training piece. I think nationally, we're building a lovely network of incredible working professionals in all aspects of that, in the research, in the advocacy, and really trying to share this message as consistently as we can. A lot of training around sort of that frontline provider piece, but probably the most invested area I've been in so far is the direct services. The Cridge received a grant in early 2020, and for 5 months we worked with 5 women around how do we develop and implement a bridged, a married IPV and BI service. How can we be more informed in what we do and create better services, creating better outcomes and more meaningful and quality lives for the women that have experienced intimate partner violence and brain injury. So we're the Cridge is starting to really gain some momentum as far as grants coming our way. We're taking a deeper dive into a training and creating a video. I was just filming it yesterday. So there's going to be training modules coming out. And then also we have received and secured some funding around advocacy and doing a partnership with Board Voice and Jody Patterson over there to try and just continue to keep this conversation going in all meeting groups. So
Great, thank you. And I know it's going to be fabulous. I know it's great teams working at the Cridge. They're putting all this together, and then you've got community partners like Karen and Paul. It's just amazing resources to have. So Karen, jumping back to you, the one thing that the SOAR project has done is made many of us aware, if not everyone that's here today, about this incredible, heartbreaking, disturbing stat about women and brain injury. But there may be people who haven't heard that. And so we want to get that on record and ask you to share that with us now.
Sure. So, as you mentioned, this is still, it's much more on the radar than it's ever been, which is wonderful. But this is still an incredibly new topic for many folks. So the amount of research that's been done is still pretty small, but it shows that as many as 92% of women who've been in intimate partner violence will have experienced a brain injury. So pretty much all of them, really. So if you consider the fact that in the United States, the Centers for Disease Control estimates 2.3% of women in the US will experience a severe incident of intimate partner violence every year. So if you translate that into Canadian statistics in our population, that's 230,000 women in Canada a year who experience a severe incident of intimate partner violence. So go back to that 92%, that means more than 212,000 women in Canada are experiencing a brain injury at the hands of a partner due to intimate partner violence every single year. So the thing to consider is that the conversation is still so much about sports. We talk about hockey players and concussion. We talk about football players and concussion. But if you try to compare the numbers, we know that every year about 38 NHL players, and this is a good time to be talking about this because I understand there's a lot of hockey going on right now, about 38 of them will experience a concussion every year. So if we play those numbers, that means for every one NHL player who experiences that brain injury playing sports every year, more than 5,500 Canadian women are suffering the same injury at the hands of a partner. So it's a horrifyingly shocking statistic, and it's reality from what we're seeing, and yet we're still not talking about it in a much broader sense than in groups like this that have become aware and are pushing that message out.
Right. So, and it's important to point out that those 230,000 women this year are added to the list for the year before and the year before and the year before. And this is one of the problems with our stats, particularly in British Columbia, that I have issue with, is that we say we have 180,000 British Columbians with a brain injury and 22,000 a year will acquire a brain injury. The problem is we've been using that stat for 20 years. We need to update that because they're added to the list. It keeps getting bigger.
Exactly. And they don't suddenly miraculously feel fine 12 months later.
Exactly. Okay, thank you for that. Tori, so you and I know, and many of the folks here that are service providers know that accessing brain injury, mental health, and substance use services present many barriers for the folks that we work with. But there are added elements to this for this particular population. Can you speak to that a little bit?
Yeah, sure. I think silos is always a word that we go back to. I think the more conversation we have around this intersectionality between homelessness, mental health, addictions, brain injury, intimate partner violence, or violence against women, like these are so interconnected, these issues. And the more we have these lunch and learns, the more we share this conversation, I think the more this issue, even in particular, can move forward, because we have to accept that there's so many moving parts. So one of those big barriers is just that we're still not communicating super well. I think all of the different service providers are doing their very best. I have no doubt everybody's doing their very best, but there's a lot of moving parts when we're working with these women, with these survivors. There is often a lot of homelessness is a huge issue, especially here on the island, in the South Island. We struggle with that all the time. Without having a solid home base, it's really hard to even look at implementing any brain injury strategies. If you don't have a place to live, reminders for your medication get really challenging. You know, that's a whole other ball game. So I think there's that piece, that just the more conversation and the more that we can try and work together instead of separately will reduce some barriers. And the other piece is navigation. Our systems are complicated. They're complicated for somebody functioning at 100% of the time. So when you're dealing with mental health, addictions, brain injury, homelessness, trying to fill out a housing application, carrying trauma with you and you're concerned about safety plans, then you're trying to navigate the system to make sure that you can have your income assistance and that you're, seeing the doctors that you need to see and following through with your specialist appointments and doing the homework that doctors are sending you home with. So navigation is tough, and this is a conversation we're having nationally all the time around how do we, whether that be a peer support navigator or whether we can sort of plug plunk navigators are all over our provinces and our country to try and help individuals to navigate these systems so that they have the access to the services that they deserve and need. So yeah, less silos, more navigation.
Exactly. Thank you. Okay, this next question, I actually was going to just ask you this, Karen, but I'm going to ask both of you this because as you're talking, it's broken into two parts for me. So we all know, and both of you know really well, that education is highly needed around this topic, right? So everything from the language that we use, and there's and the important term that I want Karen to address is why people should use strangulation versus choking, or strangulated versus choked, right? So I'm going to ask Karen to speak to that, and then Tori, because this education piece is so big, I would like you to address the need for cross-training in both for the women's services and brain injury services. So I'm going to let Karen talk first about terminology, language that we should be using and be careful of, and then you could talk about cross-training.
Sure, thank you. I also wanted to mention another one of the huge barriers we still face because this is brain injury from intimate partner violence is the shame and stigma that are still so wrapped up in this issue, and women still not feeling comfortable to disclose the mechanism of injury. And the topic of strangulation really fits in with that because we know that half of women in intimate partner violence have been strangled. We know they have, it's common, and it is the biggest red flag for future mortality. We know that women who've been strangled are 750 to 1,000 times more likely to be murdered on a subsequent incident. And yet women themselves don't know this. This has become part of their normal, as we know with much of the abuse. And we also normalize the notion of choking. So Janelle mentioned the importance of language, and this is a really key piece. You know, we talk about choking, they talk about, you know, in these fighting things, MMA or whatever it's called, you know, they say they choke someone out. The only way you can choke is if something blocks your airway from the inside. When you choke, it's on a piece of meat or something that's been caught in your throat. To be strangled is to have an external force, whether it's a hand or a ligature or a body part that's cutting off the breathing. It's really important that we use that language because it shows how harsh and how dangerous this is. We know people being strangled can cause brain injury and it can cause death. But again, it's been normalized through MMA fights. It's been normalized because so many women experience this. There are those who pretend it's part of sex play, but it's something that can kill, and it's not something that we want to trivialize. However, when we're speaking to women, we need to use language that resonates for them. So if we use the term strangled and say, does your partner ever strangle you? If the only word she knows is choke, she might say no. So we prefer in the women we're dealing with to use descriptive language. Does your partner ever do anything to you that makes it so you can't breathe or you see stars? Same with talking about concussion. Has your partner ever given you a concussion? She's going to say no. But if you say, does your partner ever do anything where you black out or you see stars or you have headaches the next day? That's the sort of language that needs to be used. So we absolutely have to use proper terminology like strangled and strangulation, but we need to consider our audience, and when we're speaking to women, make sure we're getting the information we require by using descriptive language.
Thank you very much. Thank you. Tori, cross-training, the importance of that.
Yeah, sure. And right before I say that, Karen, thank you for bringing that up. I think that language conversation is huge. And the point you brought up about stigma. I just wanted to go back to that for one moment too, because it's highlighted another barrier that we often see. This population in particular, accessing medical attention for their injury is low. It's low, and it's often then not documented in a woman's file, or it's historical. And it's been something that's happened, you know, 10, 15, 30 years it's been going on or started. And so there's often not a documentation in there in a sort of in that pathologizing medical file that highlights there's a brain injury. Without that, it's often makes a woman ineligible for services. You know, there's nothing saying I have an MRI that shows I have this damage to my brain and therefore I qualify for this service. So that is absolutely another barrier to highlight for sure. Cross-training. Cross-training, I'm going to speak just specifically to my experience because earlier, right around the same time we were doing that grant for direct services here at the Cridge, we welcomed all of our women's program IPV workers and all of our brain injury contractors that are working out, doing outreach in community, and said, let's talk about what each party does, what each program does, what that service looks like, and what might, from that brain injury side, in that IPV work, what might a brain injury look like? How might that present? What could be some sort of flags or indicators that a woman is dealing with a brain injury, whether she identifies it or not? If on that worker side of things, you can go, I'm noticing she's missing all of these appointments. I'm noticing that every time I send her with a form, she never completes it. Is it because she doesn't want to complete it, or is it because she can't? So it's kind of looking at, or can't without support, I should say, because often walking through those steps and tasks together is a much more successful, you'll see a much more successful outcome. So just having that conversation around, hey, here's some indicators of a brain injury. Here's what some signs and symptoms might look like. And if you see that in a woman you're working with, here's a couple of tips and strategies you might want to try that makes your work easier and her life easier. Right? On the other side, a lot of our brain injury contractors were really, they gained a lot of insight and awareness into safety plan. That whole idea, why didn't she just leave, right? Those are conversations, those are questions people ask, and without having a little bit more understanding of that sort of that trauma-informed piece and that dealing with trauma and what that looks like, you sit in that place, right? So it's just sharing information so that we can all be more enlightened and more sensitive and compassionate to the people that we're working with.
Absolutely.
That trauma-informed lens is so critical, and it isn't there. There's such a chasm for, you've got the folks who know intimate partner violence, and we're teaching them to understand brain injury, but helping those medical professionals and those brain injury clinicians and specialists understand those nuances and complexities of intimate partner violence, and shattering some of the myths that they might have around it, and teaching them, when you speak about language, the right language to use and the right and wrong things to say to a woman is huge in terms of us actually be able to provide service and support.
Absolutely. Very important. Thank you. Well, we might have only time for one more question. So I'm going to ask Tori to respond to this one. So we know that the CRIDGE has identified in their work that in a small research piece that they did, that a large number of the abusers themselves had a brain injury. So in terms of prevention, violence prevention, what do you and we have like 1 minute left. What do you anticipate the education or the work will be done in that area?
Yeah, I think there is still a lot of work to do and research to do for sure, but just the idea that often in our brain injury work with survivors, which at this point until now have been mostly male, a higher percentage of our survivors and clients are male, our work is often around emotional regulation, right? It's that education and understanding of how to regulate emotions. So in some ways, brain injury work in itself has a prevention aspect, right? How do we regulate? How do we cope? How do we deal with struggles and challenges that we have so that we can live a more productive life and be safe around others, right? The idea of working with abusers to talk about that brain injury and maybe look at it from a more psychoeducational, right? Violence is not okay. You may be suffering from a brain injury. What does that look like and how does it present itself? And what can you do about it? The idea would be that if we can come up with a way to serve that population better, that we would lower those recidivism rates.
I know Tori and I have talked about this as well, about DBT, dialectical behavior therapy, is one of the modalities in counseling that's coming through loud and clear that works really well with brain injury survivors, and because it is all about emotional regulation. So the challenge with that is you have to have a team, which we hope someday to have at CGB, because it is a 24/7 support for these people. So yes. So thank you both. I mean, this has just been so enlightening, and we will come back for final comments to both of you, and you can let people know how to reach you. And Karen, we didn't get to talk about the CAT, the concussion assessment training tool, but people can reach out to you about that. And I thank you both for your information and enthusiasm to be here today. Thank you. I'm going to turn it back to Shauna.
Wow. Thank you very much, Janelle, and to Karen and Tori. You've given us a lot of information from incidents through navigation, language, cross-training, stigma. There are indeed a lot of moving parts. One of the things that we wanted to do with this series is seed conversations with you, and particularly that you can get together with others who are joining us today and talk about what these topics mean to you, how they show up in your community. And so if we were face to face, we'd have you in small groups, but in Zoom, of course, we do breakouts. So we're going to move to breakout rooms now. You're going to be randomly assigned to work in pairs. Now, we'll see how the numbers work. There might be a group of 3, but mostly it'll be working in pairs. And we'd like you to talk about 3 things in that breakout room. What stands out for you most in the interviews? What ideas are from the interview are most relevant to you and your work? And who can you talk with in your community to raise awareness of IPV and brain injury? This is all about raising awareness. So it's really how has your awareness been raised, and how can you help others to raise their awareness? You'll have 10 minutes in the breakout rooms. Please turn your video on, unmute yourself, and engage. Make sure that you both get to speak. Begin with a brief sharing of your name and where you live and work. Paige will put the questions in the chat, and if you're working from a laptop, you should still be able to see chat when you get to the breakout rooms. If you're on a phone, you may not be able to see them. So what stands out for you, what ideas are relevant to your work, and who can you talk with in your community? Once you're in the breakout rooms, Paulina will send a message just to remind you of those questions. It's about 10 minutes, and you'll get a 60-second notice that the breakout room is closing, and that's really for you to wind up your conversation. And after 60 seconds, you'll be returned to the main meeting room. So any questions about breakout rooms? I hear none, I see none. So Paulina, please create the breakout rooms, have great conversations, people. See you back here in 10. Thanks, everyone. Wonderful, welcome back. Welcome back, everyone. And I think that's everyone. I hope you had really good conversations, and I hope the Zoom yank back into the main room wasn't too difficult for you. We have about 7 or 8 minutes before we begin our closing. It's gone that quickly, and we'd really like to hear from you. I'd like you to hold that thought about who else in your community needs to hear about IPV and brain injury, because we're going to ask you about that on Mentimeter shortly. For now, we'd like to hear back about what stood out for you in the interview or in your breakout conversations. We won't ask for feedback from every group, but if you're comfortable, please raise your hand or go to reactions at the bottom of your screen and raise your hand that way. And I'll invite you in to speak. I think I can now see just about everybody. So who would like to give us a quick report back on what stood out for you from the interview or from your small group conversations? Who wants to start? Oh, thanks, Megan. Appreciate.
Just a really small comment. I had a really lovely conversation about normalizing the brain injuries with this population. I think this population is already so marginalized and misunderstood. And so I really learned a lot. I think it was Candace who brought that up. I think as a woman in general, having a brain injury is really difficult. And then you add on that extra layer of trauma and violence. And so I just thought that I would share that really stuck with me to have this conversation of it just being something that is, in quotations, normal. And then that opens up the dialogue and the awareness. So thank you for sharing that, Candace.
Great, thanks, Megan. Thanks, Megan. Who else would like to share a thought about what stands out from your breakout or from the interviews?
Shauna, while we're just waiting for anybody else who wants to say something, I'll just add on to what Meg said. One of the other questions Janelle and I had talked about prior to the session was about that, whether you disclose you have a brain injury or not, and what that's like, what that experience is like when you're working with women. do I disclose I have a brain injury to my employer or to other friends, or to a partner, or do I not?
Mhm.
And it's such a personal choice. And so a lot of the work that we do is around talking to the women about the pros and cons of that. Unfortunately, for a lot of the women who are in this IPV-BI world, it is weaponized against them. Having a brain injury, it's used against them in court, it's used against them in custody situations, it's used against them as far as employment goes and accommodation. So it is I think that's a fascinating conversation. And Meg, you just made me think of that. Like this, it's something to certainly consider in working with women who have experienced IPV and BI.
Wonderful. Great. Candace.
Yeah, I just wanted to sort of add that, I mean, I think it's actually extremely sad that we have to normalize brain injury, and that, you know, underneath all of this is an issue that we have not solved the problem of men using violence against women. But the reality is that with the numbers that Karen discussed, that I think in our transition house settings, in our women serving agencies, that just having general conversations about how common brain injury is, it just opens the door a little bit, and it just destigmatizes the issue a little bit. But I just want to say it's just not right. And so I don't want to sort of be flippant about that, but.
Yeah, so language is really important, as Karen said. So it's not really normal, but it can be a consequence, right? And so how do you find the language that you can relate to your client with, right? Without setting them up, as Tori says, for that to be used against them. Amanda, please go ahead.
Hi, so I'm with the research department in Island Health, and I did hear research mentioned a couple of times during the interview. It's so wonderful that community groups are really taking a lead to really generate knowledge from women who've experienced intimate partner violence, about their experiences, what they need, the challenges they have navigating the system. And the big challenge is really crossing the gap from what we know and what we learn through the research into how we deliver care and services. So I'd be curious to know more, I guess, about how the CRIDGE is, or other centers are partnering with their local health authorities to try and get the attention of people who set up these programs, especially when you have silos between things like mental health and substance use and culturally safe care and intimate partner violence, when someone could be experiencing or impacted by all of those different areas. But I think that's a big challenge, is moving the research that's coming from community groups and people with lived experience into policy and practice. And just a comment, I guess, on that.
Right, thank you, Amanda. Absolutely true. Now, Karen, your SOAR project is a research-based initiative. Did you want to make a comment on that?
Sure. So our partnership with SOAR is University of British Columbia, Okanagan, and the Kelowna Women's Shelter as sort of the key community partners. So all the work we do is research based and evidence driven, but then moving towards turning that into practice, policy, procedure. So we're doing that on a number of fronts. The work we're doing on education, and we developed a tool called the Concussion Awareness Training Tool. That's going to be used as part of a training video for Ministry of Children and Families child protection social workers across the province. In the next year, we're going to be developing that. So that's really exciting in terms of taking that knowledge and putting it into practice in the real world. We're also just starting a research project in partnership with a forensic nursing clinic in the Lower Mainland called the Embrace Clinic. And they work with survivors of sexual and intimate partner violence mainly. And we're doing reviews of case files of their patients for a number of years. I think we have like 300 case files to look specifically for mechanisms of injury that involve blows to the face, head, and neck, and strangulation, in order to highlight how common this is for not only the health sector, but also for RCMP, so that we can affect some policy change and some practice change in those areas. We're also working with our Interior Authority locally to do a review of patient journey mapping through the system in order to work with them to create some better processes for that.
That's wonderful. That's some really good examples of research. And as healthcare providers, a number of whom are on the call today, research informed practice is really important. So we're coming up to the end. Gosh, an hour goes really quickly. I'd like to invite Karen and Tori. Maybe we'll start with Tori because Karen just had a word, but to help us close the session by giving some final comments. So Tori first and then Karen.
Thank you all first for being here. I think the more people part of this conversation, the better. So thank you for just showing up, honestly. That's what we say Brain Injury Supports is all about. I'd say 90% of it is just keep showing up, keep showing up. So this is exciting. I think there's a lot more. The research is exciting. The advocacy and the conversations are exciting. I'm looking forward to where further conversations go and who hears it. So if anybody has any questions or wants to hear more about what we're doing, please email me. I think there'll be something in the chat about contacts later. Please reach out. There are so many women in our community that need this support and need this service. And right now it is not funded. So we need to keep having these conversations and pushing it forward so that the research leads into the advocacy, leads into the funding, which trickles down to the women and boots on the ground. So lots needs to still happen, but let's just keep talking about it and keep asking questions.
Yeah, I would second that. I think we need to be screaming this stuff from the rooftops, all of us. And, you know, this is about creating ambassadors who get how important this is, who've had that light bulb moment and are not going to stop until they make sure everyone else understands as well. So I feel just honored to have connected with Tori and Candace from Cridge and Janelle when she was at Cridge and now working with the center. There's so much great work happening in these tiny pockets across the country. And the beauty is everyone's doing it in order to help women lead better lives. So we're all working together, we collaborate, we want to collaborate more. So I encourage anyone who wants to know more about this or pick my brain or Tori's brain, reach out, because the kind of collaboration we can do and the way we can move this work forward and make women's lives better, there's so much work to do. So none of us is going to get bored anytime soon.
Great, thanks Tori and Karen for being part of this. And I think Paige will put your email addresses in the chat shortly. I'd now like to invite Janelle for her closing comments.
Great, thank you. And thank you to everybody for your participation, and especially Tori and Karen for being here. This conversation, was part of our think tanks in November. We developed a call to action that we are asking people to carry forward. And all of this is because we know that it's so important to move forward, expanding services and supports, as Tori said, boots on the ground for brain injury, but also those intersections of mental health and addiction, and especially in this situation of intimate partner violence and brain injury. There is plenty of information that substantiates showing that brain injury leads to homelessness, criminality, mental health issues, and often dangerous levels of substance use. The Canadian response to the COVID-19 pandemic has been incredible. And for me, it's incredible because it has showed all levels of government working on a healthcare issue. And they've looked at the health, social, and economic issues that arose during the pandemic. And up to now, we have been told that brain injury is up to the provinces and their ministries of health because it is a healthcare issue. And the truth is that brain injury, mental health, and addictions are more than a healthcare issue, and all levels of the government need to step forward and be a part of the solution. Every level of government is dealing with brain injury, mental health, addiction in some way, and they're spending millions of dollars to address it via siloed services. And it's not working. We have gaping holes in our system that include a lack of clear and consistent best practices in dealing with these intersections, a lack of early intervention, a lack of adequate housing, supportive housing, a lack of counseling for both the survivors and their family, and a lack of seamless and integrated support that meets the need of the individual for the length of time they need it, not for when someone says they should end their services. One of our participants in our think tank said these barriers no longer create cracks for a person to fall through, but instead drops them into massive chasms with devastating outcomes. So we encourage everyone to go to our website, headstogetherthinktank.com. You can also go to traumaticlifelosses.com. They're both of our websites. On there is our full report and infographic from the Heads Together think tanks that took place. We ask you all to send it to your local municipal politicians, your MLA, and copy the Premier, Minister of Health, and the Minister of Mental Health Addictions, and finally to your federal MP, and express your support of a national strategy for brain injury, mental health, and addictions. And more than anything, remember that brain injury can happen to anyone, anywhere, at any time. And we all need to be a part of the solution. And you have been, by just as Tori said, showing up here today. So thank you. Back to you, Shauna.
Great. Great. Thanks, Janelle, for your closing comments. And now it's your turn, all of our participants. Earlier, I asked you to hold on to the question, who else in your community needs to hear about IPV and brain injury? And we'd like you to answer that question in Mentimeter. So I'm going to share my screen again and show you the Mentimeter slide. The question is, in your community, who else needs to hear about IPV and brain injury? You can go to menti.com and re-enter the code 18171412, or if you left it open, you can type in your answer. You can type in as many answers as you'd like, and they will begin to show up here. Wonderful. First responders, such as police and paramedics. It's going to take a while to populate that. And while you're doing that, I would like to take an opportunity to thank people. Definitely to thank Karen and Tori for joining us today. Oh my goodness, the tip of the iceberg. There's so many things. And as you said, Tori, I believe it was you that said there's lots of moving parts. So thank you for illuminating some of those today. I really like to also thank our team members. Janelle, once again, for your vision and for your commitment to brain injury care. To Dale for standing by in the background for tech support. Thanks for that. And definitely Paulina and Paige for your active Zoom support. This has been a wonderful team experience working with Paige and Paulina to plan these webinars. And thanks for everything you did today. But most of all, thanks for all of you for joining and participating, for listening and for talking with each other, for giving us some information about who you think needs to know in your community. We're going to use the information. We're going to save the information on the poll about who else needs to know about this. And as Janelle challenged you at the end of her comments, that we're going to talk in our fourth webinar about how to talk to politicians about some of these topics. And we're really, really looking forward to that. So we'll talk about the various approaches to brain injury in our first three. And then the last one is taking the message forward. So keep giving your answers in menti.com. That's going to stay open for a while. We hope to see you next week at noon on Tuesday for our second Lunch and Learn, Surviving an Overdose, Understanding the Need for Brain Injury Support, with our guests, Councillor Maggie Hathaway of Powell River and Debbie D, Executive Director of the Powell River Brain Injury Society. They're going to share some information they have about acting on overdose related brain injury in their community. So thanks everyone for coming. Really appreciate having you